finally, so who is here to troll me? Who does not like Medicare for all and wants to attack the revolution here? All right, Lynn, I don't think that's you. Jackson, I think you're lying. All right, trolls aren't coming out yet.
That's an old Arlo Guthrie line.
Sorry?
That's an old Arlo Guthrie line.
Oh.
Calling out who the FBI guys are in the audience.
Ah, okay, so it won't work on you all, y'all then. Fair enough. Okay. All right. Well, we are really lucky to have, let me just introduce myself real quick. We're already running a little behind. I'm Stephanie Nakajima. I'm director here at MassCare. And, I'm in this movement, the Medicare for All movement, because of years of bills, denials, and lack of access to care that actually frightened me into staying away from going to the doctor. By the time I had, actual employer health insurance, I graduated, in the recession during the time when you could discriminate against people for having pre-existing conditions. I've had asthma since I was a child. I actually just stopped seeking care because I was afraid of what was going to happen. Every time I went to the doctor, there was like some unknown bill, following shortly after it. And so, my conditions just kind of got worse and worse. And then I moved to Japan and experienced for the first time guaranteed health insurance that could never be taken away from me, would be there for the rest of my life if I chose to stay in Japan. And the relief I felt was immense. And I realized actually, after I felt relief, I felt anger that we didn't have that, and my family didn't have that back in the States. My Japanese family had it, but my American family didn't. And so I decided that if I was ever going to come back to the US, it was going to be to screw up the health insurance companies. So here I am. Thank you for joining us. And let me introduce to you our guest speaker. So excited to have him here, Senator Jamie Eldridge, the lead sponsor of the Medicare for All bill from the Middlesex and Worcester district. Jamie has been just a really long time advocate of Medicare for All and a legislative ally for forever. So Jamie, wherever you are, take it away.
Excellent. Thank you so much, Stephanie, and good evening, everyone. Thank you so much for inviting me, and I'm really proud to partner with Stephanie and MassCare on making healthcare right. I see a number of familiar faces, including John Weissman, who's on the board of MassCare here, and a number of other friendly faces throughout the state. And I think that really speaks to the fact that, there is strong support for making healthcare right in Massachusetts. We've been a leader on many issues, and while we've mostly been a leader on healthcare as far as universal health insurance, coverage, et cetera, a day doesn't go by for me as a state senator where I don't hear from constituents, having significant problems with healthcare, whether it's a high bill, whether it's applying for health insurance and never hearing back, whether it's dealing with all the paperwork for medical professionals. So it's an issue that not only is a major frustration for so many people, but it's eating into our state's economy in terms of costs for businesses, for employees, municipalities. That usually those increases in municipal budgets, almost all of those increases are going to pay the increased healthcare costs for teachers, firefighters, police officers. So there's so many sort of common sense reasons to make healthcare right. I don't think I have to tell anyone here that United States is really the only developed country that does not have healthcare as a right. Just recently I traveled on a legislative trip to Portugal, where some of the tour guides who were American were saying that when they would get healthcare in Portugal, there would either be no cost or maybe $5 for all the different healthcare needs that someone had to go to a hospital for an emergency. So it really can be done. There's so many great models out there. And as Stephanie said, I am the Senate sponsor of an act to establish Medicare for All in Massachusetts. The House sponsors are Representative Lindsay Sabadosa and Representative Denise Garlick. So we filed the legislation. And, Stephanie asked, how did I come to support, believing that healthcare should be a right? And though I've always supported single payer healthcare, the sort of personal experience I tell is from a constituent where when I was running for my reelection as state senator, I was going door to door and went to the back porch of a family's house. And the family, who probably never had a candidate or elected official come to their house, when I introduced myself, they welcomed me into their house. And there was actually a big group of high school students that were doing a lot of different work around the table. And what was explained to me by the parents at the house was that their son, Andrew, had tragically died from cancer when he was young. And ever since, they had created a nonprofit called Andrew's Helpful Hands that paid for the medical bills for one family in the United States to cover all the medical bills because of what they went through, where they basically faced bankruptcy. And I was just so moved, first, of course, by what they'd gone through the loss of their son, but because of this very obviously traumatic experience, they created a nonprofit to pay the medical bills, because that's the system we have, right? And the number one reason for medical bankruptcy in the United States, in the United States is a medical emergency. So that's unacceptable. The single payer model is the way to make sure that all those costs are covered. That actually, if we're everybody in, nobody out, actually is not only fair to families that due to unique healthcare emergencies, healthcare challenges, all those costs are covered. But equally important is it make sure that we have a fair system, that I really think speaks to what at least I see as Massachusetts values. So this is the fifth term that I've filed the bill. We're working to get co-sponsors and really appreciate the interest tonight. I am, and I know Stephanie has already started traveling throughout the state. She was recently in another community I represent, Marlborough, where the Marlborough Democratic City Committee endorsed the bill and expressed support for the bill. I'm ready to go anywhere to anyone's community here to talk about the legislation. And not to go into too much detail, but for those that are unfamiliar with single payer, and I know Stephanie's going to present as well, but it's really this very simple model that through progressive taxation, through payroll tax, you pay your money to the government, and then they directly reimburse medical providers. So they pay doctors, they pay nurses, they pay hospitals, and there is no third party health insurance provider. So in the sort of idealistic, pure view of single payer, there are no health insurance companies, and government directly pays for those costs. There's no barriers between a patient and a doctor, and you can not only get better healthcare outcomes, which we know in countries that have single payer, much better healthcare outcomes, and it's probably a lot of people here know, for a developed country, the United States has the worst healthcare outcomes, including highest infant mortality for a developed country. So it's not even providing great care. And I know in conversations with some of my colleagues, some of my constituents, sometimes the commentary is, well, we have the best healthcare here in Massachusetts, and we are absolutely blessed to have amazing hospitals, amazing doctors that if you have the money, if you have the coverage, you can get tremendous healthcare, but that still leaves an exceptional amount of bills, even for middle class, upper middle class families. And the reality is, working class, less well-off residents, people that live outside of Greater Boston, where there's less access to the best hospitals in the world, we're not getting that kind of quality care. And I am very concerned with more community hospitals closing, with psych wards closing, with the mental health crisis we have, especially for our young people, is that we're really at a breaking point. And I think the last thing I'll say about single payer is that, look, every session, the Massachusetts legislature will pass, a couple of very solid healthcare coverage bills. We just passed the mental health coverage law last session, but it's not changing the system. It's a for-profit system. Premiums, copays, deductibles continue to rise. Hospitals, medical centers are finding ways, to deny treatment for those procedures that, aren't making them money, as well as health insurance companies. The only way we're going to change this is this complete reform of the system through direct payer, single payer, Medicare for all. So I so passionate about this issue. We really need more members. We need more chapters. We need more people across the state advocating, not only with your legislators, but with business owners, with municipal officials, with community leaders, because that's the only way we're going to pass this legislation, is building the broadest possible movement. So thank you so much, Stephanie, for inviting me. I'm going to stay on for a bit, but I just so appreciate all of Stephanie's great work. It is very difficult to advocate for this legislation for a whole host of reasons. So really appreciate her passion and leadership, and happy to be here. And thanks for having me on.
Wonderful. Thank you so much, Jamie. It's great to hear also your personal stories and your stories from your constituents and stuff. I think it's very powerful. So
thank you.
now I just have to figure out how to work Zoom. Here we go. Okay. All right, so I'm going to try to do a really, hopefully quick run through of the bill. This is actually more than a Medicare 101. It's like a 201. I tried to go into a little detail. I also tried to answer the questions that you asked in the form, but I'm going to try to leave also a lot of space for Q&A at the end. And then we're going to meet back here on this Zoom next Wednesday, same time, same place, 7 p.m. To talk about organizing. So today is really about just the policy, Medicare for all, what it does, how it saves money. And then next week, we're going to talk about our lobby day and how else we're going to advocate for the bill, and also give a little history of the Medicare for all movement in Massachusetts. Okay. So let me share my screen. And oops. Great. Oh, you guys can't see this, can you? Okay, one more time, sorry. Okay, share screen. Okay, can everyone see my screen?
Yes.
Great.
Yes.
Okay.
Yes.
Wonderful. Okay, thanks. And are you seeing the next slide here? MassCare's mission?
Yes.
Yes.
Wonderful. Okay, sorry. Screen sharing is very difficult for me. Okay, so MassCare, our mission, we are a single issue organization, and our mission is to establish a single payer healthcare system in the state of Massachusetts. We were founded in 1995. We're an umbrella group of more than 40 member orgs across the state. This includes unions, Massachusetts nurses. I have to give a shout out to, they're huge supporters of Medicare for all. Massachusetts teachers also hugely supportive of our efforts. Service workers and other unions, community groups, just a whole host of umbrella, we're just an umbrella for a lot of different kinds of groups across the state. And we are building a network of local chapters called hubs that are sort of responsible for organizing in their area, because our theory of change is that, unlike a lot of advocacy groups that think, they're going to get their bill passed by like whispering to legislators in the halls of the legislature, we believe that only a large-scale grassroots movement that demands fair redistribution of our healthcare funds is going to win a transformative reform like Medicare for All. And so we lobby for the Massachusetts Medicare for All bill, which I'll go into a little bit today, but today is mostly just sort of about policy, and then we'll talk about organizing next time. And so this is just to give you a little bit of background on what we've been doing. Last year we did these ballot questions. We put Medicare for All on the ballot in 20 districts across the state. The question was non-binding, but it enabled us to send out, over 100 activists into all these communities. And this is also another, that was the partial list, and this is the other list. And I think we're going to put that in the chat so you can see it more clearly on the actual page itself. But we were able to send out people into these communities and have thousands of conversations over the course of the summer, with regular people outside of our progressive networks about Medicare for All. And what we found was actually that Medicare for All is popular among all people across the political spectrum. I had many Republicans who signed to get Medicare for All on the ballot. And that bears out when I'm, thrilled to see how well we did in areas that I didn't think maybe we would do so well in. Of course, it passed everywhere, including in Rep. Ron Mariano, the Speaker of the House's district. 61% of his constituents want Medicare for All. So Ron Mariano, if you're on this call, take heed. And so this is our bill. The House number is 1239, the Senate is 744. Again, we'll talk a little bit more about the organizing for that next time, but just to give you a sense, and I think Jamie also spoke about our legislators, our lead legislators in the House, Denise Garlick and Lindsay Sabadosa, and then of course, Senator Eldridge in the Senate. So right now we've just refiled in late January. So we're still in the process of getting co-sponsors up back to where we were last session. When we finished last session, we actually had over 40% of the legislature, over 40% of the House, and over 40% of the Senate co-sponsoring the bill. So we're about halfway there in both the House and the Senate. So again, if you can reach out to your legislators, if they're not on that map there, then please reach out to them and let them know you want them to co-sponsor the bill this session as well. Okay, so getting into Medicare for All, do we need Medicare for All when we have nearly universal coverage in the state of Massachusetts? Well, I think that statistic really sort of obscures the reality of Medicare or of medical access in the state of Massachusetts. 41% of Massachusetts families actually struggle to afford healthcare, and that includes many, many insured people and families. And as Senator Eldridge was saying, the leading cause of bankruptcy in Massachusetts is medical debt, and that's the same with the nation at large. And even though Massachusetts does have this universal coverage, it hasn't actually changed that statistic for the state of Massachusetts. We still are putting families in financial crisis because of medical debt, medical costs. And while we do have a universal coverage, or, if you read in the papers, it'll say we have 98% of the state is covered. There's so much churn in the system. So, only 89% of Black residents and 82% of Hispanic residents will have insurance all year round. And as we know, as you may have been reading the papers, about 300,000 people are about to lose Medicaid this year because of the COVID provisions that are expiring. And they're going to be churned off of Medicaid, which is, a health insurance that's very Even though there's restricted provider networks, it really covers people's costs, and they'll probably be pushed onto private plans where they'll have a very high deductible and less ultimate access to care on that private plan. And 9% of all deaths in Massachusetts could be prevented by timely medical care. Black residents are disproportionately affected. And this chart, it's a little bit hard to read, but these are the discrepancies or the disparities here in accessing healthcare across different races. So, you know, for white people, 26% actually have difficulty accessing healthcare in the state of Massachusetts, and that's really quite a lot. But then when you look at those rates for Black and Hispanic people, then you're seeing that it's really even worse. Sorry, next slide. And then again, just to drive home the medical debt here in Massachusetts, you know, 21% of white families have had trouble paying medical bills or debt, and almost 29% of Black families have the same, and that includes, and when you like break that down, that's, you know, 1 in 10, actually nearly 1 in 10 insured residents. So we're not even looking at non-insured residents, but people with insurance with family medical debt owed $8,000 or more. Sorry, just letting a couple more people into the waiting room. Okay. So all of that is happening, and meanwhile, thanks to the Massachusetts Nurses Association that did this amazing report, we now know that 16 Massachusetts hospitals and health systems have more than 1.6 billion in the Cayman Islands and other tax havens. And Massachusetts healthcare plans, that includes Blue Cross Blue Shield, nonprofit insurers, are sitting on reserves of billions of dollars as of 2020. And I think that only actually got worse during the pandemic as people stopped going to get care. And those reserves were padded even more. And of course, pharmaceutical companies are making bank, and so are hospital CEOs. And meanwhile, the amount that we're paying out of the state budget for healthcare is increasing every year. So in 2011, 31% of the state budget went to healthcare. And 10 years later, that's now, or in 2020, that's now 44%. Next slide. Okay, so I'm sorry, there's a lot of text on this slide, but I just wanted to make sure that when I sent the slide out to people, you would have all of this information. But essentially, it's telling us that what we already know now, right? Mega corporations that fight minimum wage hikes and fair labor standards are not paying for their employees' health insurance. So I think the example that's called out here specifically is Walmart, and then Stop and Shop are the two worst offenders here. And this report was done by the Massachusetts Division of Healthcare Finance and Policy, which sort of split and became, I think, CHIA and something else. And they have not updated this particular statistic since, what, 2010 or something. So I don't know why, but we can only assume that, you know, this has actually gotten worse as, you know, healthcare costs have gone up and employers seek to sort of push healthcare costs onto their employees. And so, you know, this is another way I think Medicare for All is going to ensure that everyone's paying their fair share, including employers. Okay, so let's talk a little bit about how Medicare for All would work. Let's talk about, you know, the solution to all these problems. So Medicare for All would replace the health insurance industry with a publicly funded healthcare system that provides comprehensive care without cost sharing. So that means no copays, no deductibles, no premiums. That's going to be done through the tax system, no co-insurance payments, and no out-of-pocket costs. And what is covered under Medicare for All? So again, we have precedent in all of the other developed nations that have chosen to publicly finance their health insurance system. And all of those systems cover all necessary medical care. And that can also mean that they're actually covering more things than you will get under the insurance system in the US. Or at earlier stages of disease, certain treatments are approved at earlier stages of disease for in other countries because they are bargaining for example, expensive or experimental medications. They're getting a better deal on than insurance companies in the US, which aren't bargaining as, you know, one unit. And so actually there's evidence that there's actually more comprehensive care in single payer systems, which is you know, really goes against the idea of single payer systems as being rationing. We're actually the ones who are rationed. But I think some of the important things to point out about all necessary medical care is it includes reproductive care, including abortion. It includes dental, vision, and hearing, which is a huge hole in our current health insurance system. And it includes nursing home and long-term care. Again, long-term care is not something that Medicare currently covers. And so you have to, you know, spend down everything to get on Medicaid if you want any qualification for long-term care. And that's a huge, huge problem for people as well. Another question I think that's just really interesting and has been interesting from my experience in the, you know, I have lived in Japan and then I lived in Denmark, is that networks are a thing in like, you know, you have a network and you can only go in network unless you want to incur an out of network cost. That whole network thing is a private health insurance thing. It's not what other developed countries, people in other developed countries do not understand the concept of networks. So under Medicare for all providers would be covered because using the monopsony power of the government, that would compel all providers to be in the system. Currently, patients on Medicaid and even Medicare can struggle to find a doctor who takes their insurance. That's actually one of the ways in which people say they can't access care is that their insurance was not taken by the doctor when they called, or often they don't have a time slot within the time in which they need. So that's one way that insurance companies actually bring down costs for themselves, is like by creating a restrictive provider network, because you know, if you have fewer slots of time of doctors to see, then you're going to pay out less of your insurance fund to actual care. And that's why insurance companies create such things as networks. Next slide. And who is covered? All residents of Massachusetts would be covered, regardless of their employment, whether you lose your job or not, you still have healthcare, your citizenship status, your age, you know, your income, your gender, your health status, from cradle to grave, everyone would have it. And that actually ensures that we save money on the health insurance system, because eligibility checks are also really a wasteful thing we do. We don't need to check for eligibility for healthcare because everybody should have it from cradle to grave, right? Next slide. So how will this affect, all right, just gonna let this person in. Okay, how will this affect seniors? Seniors will receive more and better benefits. So glasses, dental, long-term care, cap on out-of-pocket costs. Obviously, there's no cap on out-of-pocket costs right now in traditional Medicare. You need to get a Medigap policy for that. And then on top of that, you'd have an expanded network. Every doctor would take your Medicare and the single payer healthcare system. And then the trust would also pay for your cost sharing to the Medicare. So if you pay your Part B premium, you wouldn't have to pay that Part B premium anymore. So that's like also a benefit to seniors. Small businesses pay some of the highest costs in the state for health insurance, so they would better be able to compete with larger firms. Cities and towns would see huge savings on employees and retirees' health insurance and their benefits, and could spend that on other things that the city and town needs. And unions would be able to take insurance off of the bargaining table and start fighting for better wages or better working conditions or whatever else unions would rather be fighting for. Okay, and now we're getting a little into the weeds here. So, we're already paying for healthcare in Massachusetts with the highest prices in the world. That's actually not a exaggeration. I think that we are one of maybe Alaska, or there's another state that has like really high healthcare costs, but we're far and away compared to all European countries per capita. We're paying way, way more. But instead of our healthcare dollars going to offshore tax havens, they would instead go to care, and all of this, the financing would be done much more equitably. So right now, if you're me, then you're paying $650 a month, or MassCare is paying $650 or maybe $700 a month for my healthcare, and that would be replaced with progressive taxation, so a percentage of income, which is much, much more fair, because I should not be paying the same premiums and copays and deductibles as Bill Gates or whoever is rich in Massachusetts, the Yankee Candle guy. So again, getting a little bit into the weeds here, employees and residents of the Commonwealth would pay 2.5% of their tax on income, exempting the first 20,000. So that's a progressive sort of addition there. And then employers would pay 7.5% of payroll, or 8% for large employers. And this actually is, when we cost it out, even for people who have high tech salaries, this actually comes out to a net savings for both employees and employers. And this is also, again, the way that most single payer countries around the world pay and finance their health insurance systems. Retirement accounts, including Social Security, pensions, et cetera, are not taxed. Unearned income would be taxed at 10%, excluding the first 20K, and the bottom 90%, like the biggest takeaway here is the bottom 90% of earners will pay less than they do now. So just to give an example, at a salary level of $75,000, let's say you make $75,000. As an employee, you would pay $1,375 annually as a payroll tax. Your employer would pay $4,125 annually. So that's a total of $5,500, still well below what is paid today for employees' health insurance. MassCare, for example, pays for my insurance $8,000 a year, and I'm not making $75,000, so they would be paying quite a lot less. And to give you a city example, so the city of Marlborough is currently spending $73 million on salaries and wages for its almost 1,600 employees. It would save quite a bit of that, 16 million. And if the employer decided to pick up the entire 10% and not have the employee pay 2.5%, then they would still save quite a lot of money there. Okay, so I want to leave a lot of time for questions, so I'm going to try to race through the rest of this here. But the savings in the existing, so the savings for Medicare for All is broken down here in this pie chart. And this all of these figures come from Professor Gerald Friedman's report, which sort of assesses what would happen if our bill was implemented. So this is really getting into the weeds here. It's very exciting for me. I hope it's exciting for you. So first, let's talk about insurance savings. So this light blue part here is insurance administration, and this yellow part here is provider administration. and this is in the 100,000. So that's 9.8 billion and 8.8 bill. So yes, so in Massachusetts, right now, the current actuarial value of, private health insurance plans, it's just really, we're spending so much on insurance administration. That's nearly 12%. So, there's wasted costs on advertising, marketing, redundant bill reviews. So all the times that insurance companies just want to like review your bill and see if there's like any way they can get out of paying it. Lobbying, of course, lobbying against Medicare for all, and profit. Whereas traditional Medicare has a medical loss ratio, and that just is a fancy way of saying that Medicare spends less than 2% on admin. So because it doesn't have to do advertising, marketing, bill reviews, whatever, lobbying, or profit either. And so raising the sort of amount that we spend on actual healthcare versus the amount that insurance companies are spending on like the administration of healthcare would save Massachusetts $10 billion. So that's one really big chunk, is just insurance administration. So physicians were sort of in the same spot here. So physicians in the US devote 1/6 of their work hours on admin tasks. This is what's happening to medicine right now, actually. That is 4 times that of Canadian physicians. And simplifying the reimbursement process would save physicians about 6 hours per week. And that 6 hours per week that physicians would be spending on, calling in prior authorizations or whatever else, that could be put back into the system in the form of actual health care. So it's really like a win-win on every way you look at it. And there was just a study actually that came out in the paper, I don't know if you all saw it, but that doctors are burned out. This is nationally, but the study that I was reading was a Massachusetts study, and it was the majority of physicians here in the Commonwealth are experiencing burnout. And 27% of those surveys had already reduced their clinical hours due to burnout. So I just want y'all to look at these common causes of burnout. Increases in documentation requirements, non-medical administrators overreaching into medical decisions, time spent on prior authorization needs. I think that there are some things that Medicare for All cannot fix that are part of the healthcare system. And I think this is partially one of them, in that we simply do need to generate more healthcare workers, especially for the coming population shifts. However, the private health insurance system is driving the precious few doctors that we have, and this doesn't go just for doctors, but also for nurses and other kinds of healthcare providers. It's driving them out of the practice of medicine. And so in this way, Medicare for All is, killing several birds with one stone here by being a way, I think that actually if we created a Medicare for All system in Massachusetts, then we would be able to actually attract doctors. People say, oh, we're going to drive doctors away with like price controls or whatever. But I think we're actually going to see doctors come to Massachusetts so they can practice medicine without interference from administrators. So now let's talk a little bit about the hospital price adjustment part. And this part is sort of the one biggest part, I would say, in the whole savings system here. So if anybody ever tells you, and you might hear this from legislators, or you might hear it from maybe hospital executives, that we can't have rate setting in Massachusetts. Well, we have had rate setting in Massachusetts. We used to have it. We don't have it anymore because of deregulation. And that has created the situation in which we are in now. So monopoly pricing is not just, we talk about monopoly pricing in pharma, right? Like, oh, this, Pfizer just increased the price of this drug by X percentage or whatever. But hospitals actually do the same thing. The Massachusetts Attorney General a decade ago warned that elite hospitals are charging 4 to 5 times as much as other providers for the same service. And the crazy thing is that there's no correlation between hospital prices and health outcomes in concentrated markets like the one we have in Massachusetts. And if anybody also thinks that we can't do this, Maryland has been paying hospitals Medicare plus 7% rates, including world-renowned Johns Hopkins, under its global budgeting system, and has actually seen improvements in health outcomes. So since 2014, the rate of hospital readmission has decreased by over 21% versus a decrease of only 5% nationally. And that's because the incentives are different in the global budgeting system. And so just to be clear, the way that Medicare for All would save money here is by charging Medicare plus 10% rates. So it's actually even more generous than what Maryland would be doing, or Maryland is doing right now. And it would be phased in over 4 years. So there would be 25% savings over the course of 4 years to give hospitals a chance to dial down some of that wild pricing. Let's see. Okay. And then the last two things are just fraud. Oh no, drug and device pricing. I will go over this really quickly because I just want to leave some time for questions. So drug prices, as we all know, are 60% higher in the US than in Europe or Canada. And basically drug manufacturers are just making bank off of the US market because other markets have already sort of put a stop to it. So 40% of that revenue is coming from us here in the US. And in Massachusetts, particular, pharmacy spending outpaced all other categories of growth. So comparing to insurance, how much insurance costs have risen in the state, actually pharmacy is really outpacing even that. So it rose 9.6% from 2019 to 2021. And then in 2021 alone, it increased over 11%. So this is an area where there's just like absolutely no accountability going on. And then the final two things are, let's see, yes, fraud and physician price adjustment. And that's mostly for like really elite level physicians, obviously primary care physicians, I think would end up even making more money when you look at the Medicaid adjustment and the Medicare adjustment. So it's, Medicaid would be bumped up to Medicare plus 10% and Medicare would be bumped up to Medicare plus 10%. And then they would also be able to bill more because they're not spending that time on paperwork. So just going to skip that. Okay, so I'm going to stop here for question and answers. I see there's 62 questions in the chat. Wow. Somebody could raise their hand, actually. Hi, Brian.
So the notion that reimbursements are Medicare plus 10% is not one that I've seen. Is this incorporated in the bill? Did I miss it?
So this is actually just a prospective funding mechanism that Jerry has put together. It's not in the bill yet. This is something that sort of has to be worked out in the committees. But it is sort of like what we're using as how this would work.
Good, understood. Thank you.
Sure. Great. Charles.
Is that me you're calling on?
Yes.
Yeah, it's a related question and one that I actually asked when I registered, which is it in the bill as it is in Canada, in which hospitals receive a global budget rather than billing individual patients? Is that in the bill?
Yes.
Yeah, it is, but it's not quite the same thing as Canada because we would need to get a full Medicare waiver from the government. Right. So rather than relying on, whether or not the federal government wants to do that, then we would essentially sort of create like like a wraparound to that. It depends on sort of what we get out of federal negotiations, but there are many ways to do it, so.
And if I could just follow up quickly, with this bill, does this cover medical care, say emergency medical care that was received, say for a student studying abroad, or for an old guy like me traveling abroad? Right now, my supplemental Medicare insurance does actually cover that. Would this also cover that?
I believe it does, but I will punt that to John, actually.
I get that hand down. I was responding originally to the idea that reimbursement rates would be stated in the bill. So far, it's MassCare's policy, and we have the legislators agreeing with this, not to put that in the bill. That as bill writing, the best way to write a bill like this is to have an administration that is totally publicly accountable, which we've set up in the Massachusetts Healthcare Trust, and then have them negotiate the rates with doctors groups or even individuals, but mainly the hospitals are the big issue for a lot of people. In other words, it's not something we kick to the legislature, it's something we kick to the trust fund. As far as coverage when you're traveling, there's a reciprocity understanding in the bill that we will cover people who are traveling in the state, but then we will bill their insurer. But being state-based single payer, all Massachusetts residents will be covered when they travel. The big issue that is not clear is, what if they come up in the system and then retire, heaven forbid, to Florida? We're thinking they lose their insurance at that point. But yes, if you're in the system, you are in the system anywhere in the world.
No.
Cheryl and Henry?
Hi, thank you. I have a couple of questions. One is, I didn't catch, are we dependent on the Medicare waiver from the feds?
We're not, because, it would be good if we had it, but if we don't, then we create a wraparound program that both sort of like pays the Medicare Part B premium and then covers the things that Medicare doesn't cover.
The other question is, would the Medicare plus 10% reimbursement for hospitals make it satisfactory for critical access hospitals, which get a higher reimbursement right now? And we have one in our county that's very important to this county.
Yeah, so, well, first of all, teaching hospitals would still get the additional amount that they, receive from Medicare for being a teaching hospital. And then I would say safety net and, rural, those hospitals really stand to gain from Medicare for all, because they actually bump up the rates, for a lot of like Medicaid and, uncompensated care wouldn't be really a thing anymore. So just having an evening out of the rates actually really levels the playing fields for hospitals that serve unprofitable forms of care, like ER care, not profitable. So.
And one more question, if I might. What if we're asked, is this going to encourage unemployed people from other states to migrate here?
If they can find housing.
Housing shortage?
Um,
Seriously, what's the answer for that if we're asked that?
We
Yeah,
need more people. We're losing people.
Okay.
Yeah, we are losing people. I mean, I also think that, there isn't a mass exodus of people from Georgia to Massachusetts, even though, sorry, I'm saying this coming from Georgia. What you can get in Georgia is absolutely nothing. If you're, poor, you don't have a job, whatever, there's actually already all sorts of benefits that people can get in Massachusetts that people in the South can't get. So I don't see I see people, I don't see that kind of, I don't see that really happening. And I just want to, before, I will absolutely stay on to answer people's questions, but before we leave, or before people start jumping off at 8 o'clock, I just wanted to encourage everybody, please sign up for Medicare, please sign up for MassCare. Please, you can volunteer to be part of our lobby day, actually, which is going to be May 4th. And we are going to, again, next Wednesday, today was like the policy day. I wanted to spend at least 1 hour doing policy, but I want to spend another hour talking about organizing and how we're going to win, and where the movement has been and everything. So we're going to do that next Wednesday, same time, same place here. So please come back. And there will be more opportunities to actually get plugged in and everything at that point. And then finally, if you enjoyed this presentation and you think the Medicare for All movement deserves more than one employee, one person fighting at MassCare, then please donate. And I think we're going to put the donate link in the chat here. So Bob.
Yeah, thank you, Stephanie. It's been a great presentation. I really appreciate it. I had an unusual question from a couple of providers, and that is they wanted to know if they chose to do some self-pay work, people who would prefer to pay out of pocket. I can't imagine there are too many of those. Could they accept those people as patients outside of this system and maybe still be able to see other patients within this system?
Yeah, they absolutely could. I mean, I don't know if people would want to pay when it's already covered under like the whole system, but that is sort of a problem we're experiencing right now with like mental health care.
Yeah.
That it's essentially almost entirely outside of the paid system. And so there's mental health care is much more accessible to people of higher incomes. And that's something that I hope single payer will fix, at least partially. So.
Yeah, I certainly hope so too, as a retired clinical social worker. But thank you for that answer, and I'll take it back to those people.
Okay, thanks. John, do you have a question?
No, I just want to address a question that's in the chat about Jerry Friedman's assumptions. He did start with Medicare rates, but he improved on them, as you said. But also, he's going to do a presentation on his entire methodology on April 26th. So everyone who's on this call who is not a subscriber to MassCare should go ahead and subscribe, and you'll get the word about that. Or if you're a member of an active hub, you'll get the word that way. Again, though, keep in mind, he's not writing the law. The law does not set rates. It's entirely up to the trust to come up with the rates.
Yes, exactly. This is just his proposal. But I think that, there's room within this proposal to wiggle and still actually have savings.
Yeah, actually, Stephanie, he created a budget for the new trust fund that has a small surplus every year.
That's right. Yes, it also has a surplus.
Wiggle room.
I gave the quick and dirty version of Jerry's thing today. You guys can see the real thing from him in a week or so, or whenever.
In a month.
Month. Frank.
Yeah, Stephanie, thanks. It's a great presentation. I've learned a lot. There was a recent article in Public Citizen News about private equities taking over medical facilities, milking them and then reselling them after 2-3 years and saddling them with debts to the point where they can't provide adequate services. Now, would something like that require, there'd be no incentive, I assume, under Medicare for All for this kind of engulf and devour situation, but could it still go on, and would it require separate legislation to prevent those kind of things from happening? I know this is a tough question. I know. I didn't mean to.
I would say that, yeah, obviously the incentives would be different, but obviously that's not going to stop them. And I do think that ultimately, if we want to get a handle on how our health care dollars are spent, if like, because there's still an incentive for, high profitable hospital chains and whatever to like invest in profitable forms of care that's actually not that great for the community or is like not serving the community. And so I think that, again, that's something a little bit outside of the single payer insurance system. I would personally advocate for socialized medicine at that point, where you're actually also controlling where hospital, resources are going. The Danish system is like this. And when COVID happened, it was like, bam, they were able to like dedicate this, hospital and wing to testing and COVID, everything. Like they just didn't, it was just a much more integrated system that was ready for a public health emergency. And our system isn't really ready for that. So
Yeah.
that's a very unsatisfactory answer, but.
Probably I think it would tamp down that program, because one of the ways they operate these private equities, they charge exorbitant fees once they take over these medical facilities. They charge whatever they damn please, and they try to make as much money before selling. If the rates were controlled, there's probably much less incentive for them to do those kind of engulf and devour, things.
Yep. Sneak attack against the profiteers. Eliza?
So we had a question in the chat. This is from Barbara. Will Massachusetts Medicare for All bills cover gender affirming care?
Yes, it will. Sorry, I should have had that in the presentation.
I don't see it in the, I've sort of looked through, and it says that it's for people of any gender identity and so forth. But then when it actually lists, it says reproductive care. I don't know, it doesn't actually say it. But of course, as John has said, it's up to the trust, and it's up to the administration of the trust if that's a pressing thing.
I thought we strengthened the language in this version of the bill, but maybe did we not explicitly say that, John?
No, it's a doctor-driven system. Got to remember that. The practitioners are getting reimbursed, and there's no decision really by the trust not to cover something that's medically necessary. What we do in the bill is we have a list of things that we are telling the trust they must cover. And some of these are because of controversies out there in society. Long COVID is on the list, even though it's already covered by the medical necessary term. And so would be abortion, even though it's already covered by the medically necessary term.
Mm-hmm.
So if there's a feeling that for politics, we should include gender affirming medical care, then we will add it because we want to send a message to the trust. But it's already there because it's medically necessary. So it's worth breaking. If it's not on the shopping list, it's worth breaking it out and putting it in.
I guess I don't understand. I was under the impression that doctors who didn't want to do that could say it's not medically necessary.
You're starting with the patient. The patient finds a doctor. The doctor diagnoses the dysphoria. That leads to insurance coverage because there's a doctor bill.
Okay.
Yeah, if that I thought we had strengthened that language in this version of the bill, but if we haven't, we definitely will go back and make sure it's clear, I guess. Eliza?
It definitely says it covers gender, and of anybody of any gender identity and so forth. Definitely says that. So you might have put that in this time.
Okay. Yeah, I'll take a second look at it for sure. Eliza?
And just one more from the chat. There's a few folks who are still concerned about the self-employed tax. And so wondering if there's any discussion about moving it to a more progressive income-based system.
Yeah, yeah, I mean, I think that no matter how you shake it, even with the tax, the payroll tax for self-employed will be significantly cheaper than how self-employed people currently pay quite a lot for their health insurance on the individual market. So with the 20,000 K, exemption, it should still be less expensive for 90% of the population. So 90% of residents. But I'm happy to hear, other people's feelings about that. But
Stephanie, let me just add, so the payroll tax is not our choice, it would not be our choice to fund this bill.
Yeah.
Massachusetts does not allow the income tax to be progressive, and it does not allow the income tax to be used for this purpose. However, that's changing. We see that changing right before our eyes with the new tax on multimillionaires. So as the movement for a progressive tax system in Massachusetts grows, we will be a client of that movement, and we will have sooner or later the right to fund this system in a different way. But right now, our model is the Medicare payroll tax.
yeah, thank you, John. Herb?
Hi, thanks for a great presentation. I am new to the party, so I was one of the curious. I remain curious. So many questions pop up for me, but I'll try and make it succinct and quickly. So things that you guys may have already discussed. First of all, how many insurance industry jobs will be lost in Massachusetts once Massachusetts insurance industry gets shut down? Secondly, I agree with the previous comment. I'm concerned about the self-employed. It really does seem like this is working against people who are self-employed. I disagree with your comment that you think it's going to save them money. We have many self-employed people in this state who are making a decent living, and 10%, let's say you have two parents who both are self-employed, making $100,000 each, and now they're paying each $20,000 or more. Let's say they make $150,000. Now they're paying 30 grand each. For their couple for their health insurance. And these are two healthy people. You're going to drive those people out of our state if they think they have to pay 30 grand for that couple to live in Massachusetts to have health insurance. Just as an example, the last thing I'm going to bring up, somebody put in the chat the concern about in Western Mass, how long it takes to see a PCP access to care. The access to care in Western Massachusetts is mostly based on the fact that we have too few providers. And as other people have mentioned, there is a huge concern for me that we will not be competitive in our ability to pay providers what they can get elsewhere if that's not addressed in this bill on some level. Because there will be doctor flight. We've seen it before back in the 80s when Medicaid rates in this state were terribly low and we had trouble holding on to docs. And as you know, we produce more doctors than any other state, and very few of them stay. So there's a few of my initial thoughts, and I'm still curious.
Thank you for that. So to address from the back, backwards to forwards, so the PCP thing, primary care providers, we don't invest in them, and the current system actually punishes them more than the elite sort of like specialties. That's actually the problem with our healthcare system, is that, they're actually underpaid, whereas, specialists are really overpaid. And so that's why we're also driving, that was my slide about like driving them out of the system, first of all, because we have way too many administrative requirements. That's both nationwide and in Massachusetts. And by converting to a single payer system, PCPs will be more encouraged to stay, because then they don't have to deal with all that paperwork and they can spend it instead on patient care. And then a lot of PCPs, if they're accepting Medicaid patients, if they're accepting Medicare patients, they're getting, which a lot of PCPs do, of course, then they are making under, the rates that they would be making in this bill, because we'd be bumping the Medicaid payment up and the Medicare payment up. So I think that there's, a strong argument for that. This is actually, and most PCPs actually will do support this bill, and, much more so than specialists do, because, those are the winners and losers in this system, I think, a little bit. So, and then in terms of the self-employed thing, I mean, I think that, the income thing is that the income tax issue that John brought up is just part of it. But I also think that when you look at both, we're talking about a tax that's going to replace not just your premiums, but also any co-insurance you pay, any deductibles, co-pays, whatever, which can be thousands of dollars if you have a bad year. So you might be healthy this year, but you have no idea what's going to happen next year. And so I think that if a couple's making $300,000, then, it's okay for them to pay a little bit more into the system.
How about the, thank you for your answers. How about the loss of insurance industry jobs in the state? Do we have a number on that?
I don't know if do we have an estimate on that, John?
No, Jerry always addresses that in his talk every 2 years. So that'll come up on the 26th. But his general view is that the need for healthcare expansion, the part of his formula is to expand healthcare coverage across the state, that's going to absorb a lot of workers. There's also a transition budget in the plan. In the budget, there's a transition budget, and people will get retraining wherever they want to go next. And then there's the absorption since there's such monopoly. Insurance companies are now so big with such national and international monopoly that they can absorb these workers in other states. So economists who study this are very optimistic that there's minimal disruption, and that the budget that we allot in the bill, the budget that we allot for retraining, actually will not get entirely used.
But thank you for your questions, Herb, and you can always email me too if you have other ones. director@masscare.org. Betsy?
Yeah, I want to thank you for a wonderful presentation and thank the audience for wonderful questions. There are some who were the merely curious like Herb. I think you have been preaching mostly to the choir. And so Herb asked some questions that were not maybe what the choir would like to think about. But given the fact that this is the fifth year or the fifth iteration of this bill, can we be at all optimistic that we will move it further and actually have it become law than it has in the past?
Yeah, I'm actually super optimistic about our chances, more optimistic with every passing year. I mean, when I look at, MassCare has always done these ballot questions, we've done them since 1994. And when I was looking at some of the ballot questions where we've duplicated them as well. So, we did one in like Marlborough 10 years ago in the Marlborough area. And it's not apples to apples because of redistricting, but you can take out the cities and towns and look at the city and then get an apples to apples comparison. And in all three of the districts where we have done the question before, we have increased support for Medicare for all among the general population. And I just bring up Marlborough because we increased it by 9% there. It was like kind of a huge jump. So 54% in 2011 to this 2022, it went to 63%. So that's that's a really big jump, I would say. And that happened also in other areas. Pittsfield, we actually won in Newburyport, which was last represented by a Republican. We're just seeing like really widespread, support for Medicare for all. And I would also say when I go out and talk to people on the street, people absolutely have questions about Medicare for all, but when you answer them, they're like, that's right. Like they just sort of, they see the reason in Medicare for all. And it's not easy to sort of like, it's not too hard to convince them of the value of switching to a Medicare for all system. So I feel really optimistic about it. I do think like we have challenges in the legislature. The way the legislature is constructed makes it very difficult to pass. But I also think that we would need anyway a massive grassroots uprising for Medicare for all. And I think that, as I see, we were not prepared for 100 people to come. We don't have a Zoom. I feel so bad. We don't have a Zoom for over 100 people. So there are people who tried to get into the Zoom that couldn't get into it. And I didn't know that. And that's because this is our first time having this many people. So I feel like our movement is growing and growing every year, every session. And even if I'm not like super optimistic about like our ability to pass it like this session, that doesn't matter to me because I think that we're going to be expanding our support into other major constituencies that are important to passing Medicare for all. And if we do that this session, that's going to be huge to actually getting it across the finish line eventually. So I feel really good about where we are.
Thank you.
All right, I answered all of your questions.
I think we have one in the chat.
Susan.
Yeah, I just wanted to ask Senator Eldridge, who are the primary folks blocking passage of this in the Senate and the House?
I was waiting for that question.
Well, you got it.
Yep. I think the thing is that it's really not, I mean, right now it is true the House and Senate leadership, they do not support Medicare for all or single payer. And I do want to note, Governor Healy has been pretty clear that she doesn't support it as well. But the real obstacle is just getting the rank and file legislators, not just to co-sponsor the bill, but to actively, fight for the legislation. And so, I agree with Stephanie, you look at those percentages and those referenda, you look at, people being frustrated with the healthcare system, the support is growing. It's translating that to legislators, to your state rep and state senators say, I don't want you just to co-sponsor the bill, but really to fight for it and bring this up and champion and say, well, what is the state going to do to address, rising healthcare costs and worse care and different types of care depending on where you live or your income level is. So it really is the rank and file and just, keep on doing that advocating. And, if there were more rank and file legislators that fought for the bill or were more vocal, I think you would see a change in, how the leadership treats it. Right now it's sort of, not truly seriously being reviewed because it's just not coming up much from rank and file legislators. So that's where we need to focus our energies.
Yeah, because, I'm helping a friend who really needs somebody who can oversee her healthcare.
Mm-hmm. Yeah.
Someone who sees all the moving pieces and can help her with it because she's losing her ability to take care of herself. And so her friends are stepping in right now because there's very little in the system that will help her.
Mm-hmm. Absolutely. We all have those stories. So telling those stories to our legislators is really critical. Yep.
Okay, good idea.
Thank you.
Yeah.
Thank you for everything, Senator. You're the best.
Oh, thank you so much.
Jamie is the absolute best. It's true. Yeah, I would really encourage you to tell your your legislators your stories. They will try to like legislate you on other things like, oh, we can't do this, oh, we can't do that. But if you tell them your healthcare, your personal healthcare story, then they can't tell you that that's not true, or they can't legislate that away. So, and I think that that's really like at the heart of what we're doing. We're trying to make healthcare equity for all, right? And so I would absolutely, suggest you reach out to your legislators and tell them why Medicare for All is so important to you personally. Yeah. Mark?
Yes, hi, this is Mark Plant. I enjoyed the conversation, very educational, and reinforces most of my views on Medicare for All. For Senator Eldridge, I do have a question. Being a cynic that I am, what is the influence of lobbyists on actions on Medicare for All? This is a reflection of California's recent CalCare bill, known as AB 1400. It's got no votes because it got pulled from the floor on January of 2022. Democratic supermajority, just like Massachusetts. You think it'd be an easy win, but yet no votes are taken. So,
Absolutely.
appreciate your response.
Absolutely. And I'm so sorry, I couldn't quite hear the question. What was the question?
Oh, sorry, my finger was over the mic, I think. My question is regarding the AB 1400 CalCare bill from January of 22. What is the role of lobbyists in creating these no vote results, which we also have in Massachusetts?
Oh, lobbyists, sure. Yeah, sure. I mean, I will say because the support for single payer is growing, for the first time, I think it was last session, the lobbyists for MAPS, Mass Association of Health Plans, so the trade association for health insurance companies, did testify in opposition to the bill, and often they attend the hearing but don't even speak. So they are speaking against it, and I have no doubt that privately when they meet with legislators, they're saying things like it's not workable, or talking about the jobs perspective, which was raised earlier by someone else. So that shouldn't be a surprise, and we just need to keep on highlighting all the answers. The MassCare has a great frequently asked questions link that we're always adding to, including probably from tonight. And yeah, the pharmaceutical lobbyists and health insurance lobbyists will oppose this, and we've just got to use our people power to overpower that. So I hope I answered your question correctly.
Yes, you did. Thank you very much.
Yeah, thank you.
All right, we'll do Betsy and then Adam, and then I'll release you all back into the wild.
I want to follow up on a question about who the legislators are who have been opposed to this. Well, on the Cape in Fourth Barnstable, we have a long serving representative who has been unwilling, or had been unwilling, to come out as a co-sponsor. She was primaried, and all of a sudden she had signed on as a co-sponsor. So let us all know who the people are who are recalcitrant about favoring Medicare for All, single payer, and he didn't win, the one who primaried her, but it was still a very obvious difference of commitment, and a lot of her constituents were not happy that they didn't realize that she had not co-sponsored. Of course she would have. Well, she didn't. And so find somebody in your district to primary those who are not who are not stepping up to the plate.
Absolutely. If everybody on this call could commit tonight to running for office, the Medicare for All movement would be in amazing shape. So absolutely. You need the electoral. I mean, we're grassroots, we do community stuff, but the electoral is another really important component of keeping our electeds accountable to us. So 100% there. Adam.
Yeah, thank you for doing this. This is very informative. I really enjoyed it. I have two questions. First is a yes or no, or I guess, is this recording going to be emailed out to us? And if so, when?
Soon.
Awesome. And then other question is for Senator Eldridge. When you have those conversations with your colleagues, like what sort of takes place in them? And what I mean is, are your colleagues like just genuinely opposed to the idea, or they just find there's not enough, public support, or they're not getting the support, not hearing about it from their donors and businesses and whatnot? Like, what's sort of the root of their opposition?
Good question.
Yeah, thanks, Adam. Yeah, and it's a range of things. I mean, certainly there are legislators that have, say, a lot of pharmaceutical companies in their district, and they've seen, a lot of jobs, and they then counter that, well, that, that wouldn't have happened with single payer, which I always chuckle a little, because most of the major pharmaceutical companies in Massachusetts are owned by foreign companies in countries that do have single payer. So they seem to be doing quite well in those other countries that have single payer. Yeah, so sometimes it's that. Sometimes, I do think a part of it is they're not hearing from many constituents, and therefore, they think, well, this is very difficult. Some legislators have this sort of point of pride that, well, Massachusetts, we passed in 2006 near universal health insurance, and therefore, we're doing great. So I think it's important to have these statistics about, medical debt and infant mortality rate and other things. And then there are some legislators that actually say, you're right, we're gonna get to single payer, it will happen. And I usually say, well, it's not going to happen unless, you and other legislators that do agree that it's the final outcome, if you advocate for it now. So I think it's, again, to what I said earlier, getting legislators to sort of agree to that, and then to be vocal about supporting the bill. So it's a range of things. And again, I think the FAQ on the MassCare website has a lot of helpful guides to how to answer some of these questions. But certainly legislators who are strong supporters, like myself, should be, having more direct conversations with these legislators as well.
Yeah, thanks for that. I just to follow up, and I'll try to be quick because I know everyone's here late. Do you find overall that your colleagues, especially in the House, just don't believe in it, or that's some other reason? What do you hear mostly on that particular aspect of it?
I would actually say I think a significant number do believe it and see the problems with the healthcare system, but it don't have to say to anyone here that the healthcare system is so complex that they just feel, wow, how are we ever going to pass such a major reform? It's too overwhelming, and therefore, I'm going to focus on other things. So it's really getting them to focus on this as well. So
weird the State House isn't focused. Got it.
Yeah.
Agreed. Thank you.
Thank you.
Well, it sounds like you are all super interested in the organizing part of this and getting this passed. So I want to see all of you back here Wednesday, 7 p.m. We're going to talk about our lobby day again, May the 4th. And the thing that I think that legislators really need to hear from you, that this really matters. So email them, call them to follow up. There's still a lot of legislators on that list who, haven't re-upped this session, who were on last session, but could be on this session. So please contact your reps, let them know that this is important to you personally, and hope to see you all on next Wednesday when we plan the revolution.
Thanks, Stephanie.
Thanks.
Thanks.
Great job, Stephanie.
Great
Thanks,
job.
everybody.
thank you
Thanks,
for having me.
Stephanie.
Thank you. Great
Thank you,
job.
Bruce.
Thanks, Stephanie.
And thanks for folks who
Thanks,
asked
Stephanie.
good
And
questions.
Stephanie, and
thanks, Jamie.
And Betsy.
Thank you, Jamie.
Thank you.
Well, she jumped right on my, you jumped right